Welcome back. All right, today we're diving into a complex, incredibly high-yield set of clinical notes, and we're going to frame the whole thing as a fascinating physiological detective story. When it comes to women's health, what you see on the surface, the symptoms, well, they're often just the tip of the iceberg. And it's our job today to decode those underlying mechanisms. Let's get right into it.
Just to keep us on track, here's our clinical roadmap. We'll be walking through abnormal uterine bleeding, investigating missing periods, polycystic ovary syndrome, decoding pelvic pain, and we'll wrap up with the truth about endometriosis.
Okay, first up, abnormal uterine bleeding. Let's really dive into this because abnormal uterine bleeding is incredibly common. We're talking about something that affects up to a third of menstruating women. So when a patient presents with this, the sheer number of potential causes can feel pretty overwhelming. But we can bring order to that chaos using the PALM-Cohen acronym. It's such a brilliant way to break things down. The PALM side covers structural issues. These are things you can physically see on imaging, right? Polyps, adenomyosis, leiomyomas, malignancy. Then, the Cohen side covers functional issues you generally can't see, like coagulopathy or ovulatory dysfunction. It establishes our first major diagnostic framework perfectly. Are we dealing with a physical roadblock or a functional glitch?
Moving right along to Section 2, Investigating Missing Periods.
So when we're investigating primary amenorrhea, the traditional trigger age to start looking into it was always 16. But honestly, today, if there are red flags, like absolutely no secondary sexual characteristics by age 13, we start much earlier. And listen, there is a golden rule here. You must always rule out pregnancy first using a beta HCG test. That's non-negotiable. Only once you confirm that do you move down the anatomical chain. You check the outflow tract, measure FSH to figure out if the ovaries or the pituitary gland are the culprit, and then assess other hormones like prolactin and TSH.
Now, what's really fascinating about this step in the detective work is how two completely different conditions can look almost identical on the surface. Take MRKH and complete androgen insensitivity syndrome, or AIS. Both present with normal breast development and a blind vagina. But look closely at their genetic footprints. They are totally different. MRKH patients are 46XX with normal female testosterone and pubic hair. AIS patients, on the other hand, are actually 46XY with male-range testosterone and absent pubic hair simply because they lack androgen receptors. Wild, right?
Shifting gears to secondary amenorrhea, which is where periods cease for 3 to 6 months, there's a statistic here that might surprise you. 10%. That is the chunk of cases caused entirely by primary ovarian insufficiency, or POI, and that's defined as ovarian failure before the age of 40. This brings up an absolutely crucial clinical pearl. When a patient gets that POI diagnosis, screening for the FMR1 Fragile X premutation isn't just a good idea, it's mandatory. Why does this matter so much? Because a reproductive diagnosis right here directly impacts genetic counseling. Male offspring of FMR1 premutation carriers are at a very high risk for severe intellectual disability. So our detective work isn't just about treating the patient sitting in front of us, it's literally protecting their future family. All right, part 3, polycystic ovary syndrome.
You've probably already know that PCOS is the #1 cause of ovulatory dysfunction, but we have to remember it is strictly a diagnosis of exclusion. You have to rule out mimics like thyroid disease first. Once you do, we rely on the Rotterdam 2023 criteria. A patient only needs 2 out of these 3 things: irregular menses, signs of excess androgens, or a specific ultrasound or elevated AMH profile. Do the math there. They only need 2. A patient can have irregular periods and high androgens and be diagnosed with PCOS without a single structural cyst ever showing up on an ultrasound.
And while we're on the topic, let's bust an outdated medical myth real quick. For years, clomiphene was the absolute go-to for helping PCOS patients conceive. Actually, scratch that. It was the go-to. Not anymore. Letrozole, which is an aromatase inhibitor, is now firmly established as the first-line treatment for ovulation induction in PCOS. It simply provides significantly better live birth rates.
Let's move into Section 4, Decoding Pelvic Pain.
Pelvic pain is a completely different beast, you guys. It demands urgent, step-by-step triage because, frankly, the stakes can literally be life or death. So think back to that golden rule we established earlier in the explainer. What is the single most critical first step when a patient walks in with acute pelvic pain?
Exactly. You've got to immediately exclude a life-threatening ectopic pregnancy with a beta HCG test. We're looking for a discriminatory zone of 1,500 to 3,000 IUs-L. If the levels are above that and we don't see a pregnancy inside the uterus on an ultrasound, that is a massive, flashing red flag.
And here is why we do not mess around with this. 18%, even in highly developed nations with incredible healthcare access, the incidence of fallopian tube rupture for ectopic pregnancies is around 18%. That is staggering. It underscores exactly why rapid diagnosis isn't just good practice, it is an absolute life-saving necessity.
But keep in mind, our detective work isn't always strictly gynecological. Here's a stat that usually shocks people. Up to 60% of pelvic pain is actually gastrointestinal. We're talking appendicitis, IBS, diverticulitis. A truly great diagnostician never gets tunnel vision. You always have to look at the whole board.
So the crucial point to take away is how time completely dictates your investigation. Acute, sudden pain? That points us straight toward emergencies, ectopics, PID, or an ovarian torsion. But if that pain is chronic, meaning it's been going on for more than 6 months, our entire algorithm shifts towards structural and inflammatory conditions, like fibroids or endometriosis.
Which brings us perfectly to Section 5, the truth about endometriosis.
Endometriosis is a condition that profoundly impacts millions of lives, yet somehow it remains one of the most deeply misunderstood diseases in all of medicine. Simply put, it happens when endometrial glands and stroma decide to grow completely outside the uterus. Because this tissue still responds to hormonal stimulation, it bleeds, and that causes severe cyclic inflammation and pain in places it shouldn't be, like the ovaries, the bowel, or the peritoneum.
I really want to emphatically bust a major medical myth right now. The stage of the disease from stage 1 to stage 4 does not correlate with the extent of the pain, period. A patient can have stage 1, which is microscopically mild anatomical disease, and be in absolutely excruciating, debilitating pain. The patient's experience is valid, completely regardless of what the anatomical staging says.
Now, while a diagnostic laparoscopy, literally going in surgically to look around, remains the absolute gold standard for proving a diagnosis, patients should always be treated empirically first. A doctor shouldn't make a patient wait months for an invasive surgery just to prove they have the disease before finally offering medical relief, like continuous oral contraceptives or progestins.
Well, we've unpacked quite a few clinical mysteries today, but I want to leave you with this provocative thought to chew on. If a patient sits across from you with severe, life-altering cyclic pain, yet their blood tests are perfectly normal, their ultrasound is pristine, and they only have an early-stage diagnosis, how do we best validate and treat an illness that is largely invisible? It's a humbling reminder that in the world of women's health, empathy and careful, structured detective work really must always go hand in hand. Thank you so much for joining me in this explainer. Keep asking great questions, and I'll catch you next time.